the opportunity. And as we all know that Professor P.C. Manoria sir do not need any introduction. But in brief, I would like to introduce sir. Sir is the director of Manoria Heart and Critical Care Hospital, Bhopal. Sir is a former professor and head of Department of Cardiology from GMC Bhopal. And he has been past president and past chairman of various society of CSI and various societies in India. And he has delivered various lectures, and he is a editor of various books and has approximately 64 publications in various journals. So I would like to call Dr. P.C. Manoria sir for giving the talk. To you, Manoria sir.
At the outset, I'd like to thank Dr. Dhigra and his team for inviting me to this wonderful conference. For the next 15 minutes, I'll be talking on diabetes as a comorbidity, from a bystander to a driver of heart failure. The last couple of years has witnessed a sea change in heart failure care, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. We now have 4 foundational drugs for HFrEF, with sacubitril/valsartan as a preferential recommendation by ACC 2021. And all these 4 drugs are powered to improve outcome of HFrEF. The second big message is that sacubitril/valsartan has made ICD eligible patients of ejection fraction less than 35 to ICD ineligible patients within 6 to 12 months. And this is indeed a very exciting observation from the trial. And time has come to say bye-bye to switch strategy of initiating sacubitril/valsartan on ARNI after initial use of AC inhibitors or ARB, and you can directly initiate ARNI as a de novo therapy in patients of HFrEF, naive to ACI or ARB. Now, before discussing heart failure in diabetics, it is very important to understand the nuances of heart failure in diabetics and try to demystify them. All of us know diabetes executes its ravages on the cardiovascular system by 2 ways. One is the atherosclerotic pathway, as you can see, which could result in cardiovascular death, and the other pathway is heart failure. Atherosclerotic events account for 50% of the death, and heart failure events also account for the remaining 50% of death. The awareness of atherosclerotic events like acute myocardial infarction and stroke in diabetics is reasonable amongst physicians and practitioners, but distressingly enough, the importance of heart failure in diabetes is highly under-recognized by physicians and practitioners, and many times the diagnosis is totally missed. So let's understand the nuances of heart failure in diabetes and how they can be demystified. The first big message is that heart failure predates the development of coronary artery disease. Don't be under an impression that coronary artery disease occurs first and then heart failure. As you can see in this analysis of 1.9 million, heart failure precedes development of myocardial infarction. The second big message is, if you are a diabetic, you control your risk factors to the guideline recommended targets, still heart failure and hospitalization for heart failure can occur in as much as 45% of patients, as you can see in this slide. The third big message is, earliest defect in diabetic heart is diastolic dysfunction and not coronary artery disease. But unfortunately, diastolic dysfunction is commonly missed by physicians for several reasons. 68% of diabetics have evidence of LV dysfunction 5 years after diagnosis of type 2 diabetes. So you can imagine the importance of LV dysfunction and heart failure in diabetics. And 1 out of 4 diabetics have undiagnosed heart failure. Majority are newly detected heart failure. Majority of newly detected heart failure is HFrEF. And this prevalence of undiagnosed heart failure is seen in those who are elderly, females, obese, hypertensive, history of dyspnea, and those with history of fatigue. And don't be under misconception, heart failure is more often a cause of hospitalization than acute coronary syndrome. As you can see in this slide, heart failure is above acute coronary syndrome in terms of hospitalization. And look at the mortality. The mortality in diabetic heart failure is very distressing. 3-year mortality to the tune of 40%, 5-year mortality to the tune of 85%, as against a non-diabetic heart failure, where the 5-year mortality is only 50%. And don't be under a misconception. If you develop an MI or a stroke, you have quick fix, lytic therapy or an endovascular intervention. But if you develop heart failure, there is no quick fix. But interestingly, the current pharmacotherapy blunts this malignant progression of heart failure and improves survival to a great extent at the present state of time. And heart failure hospitalization is a very distressing event in the natural history of heart failure, because every hospitalization, every rehospitalization takes the patient closer to death. And if a drug can minimize hospitalization for heart failure, this is indeed a great achievement. ARNI, beta blockers, and SGLT2 inhibitors decrease hospitalization for heart failure. The other big thing to understand is when you are treating heart failure in a diabetic patient, please be clear, there is a very close bidirectional cross connect between diabetes and heart failure. As you can see here, what does it mean? If you have diabetes, it is likely to result in heart failure in future. And if you are a patient of heart failure, you are at increased risk of development of diabetes. So there's a bidirectional cross connect between diabetes and heart failure. If you have already developed heart failure, there's again a bidirectional cross connect between heart failure and CKD, which you must be fully aware of, which means heart failure, if you are having it, it is associated with CKD. And if you have CKD, this is commonly associated with heart failure. And worsening kidney failure worsens heart failure and vice versa. And therefore, the message is, if you are treating a patient of heart failure, do not treat heart failure alone. Also target CKD. You should treat cardiorenal continuum as a whole for optimizing benefit. And don't forget, targeting CKD in heart failure triggers benefit for heart. Targeting CKD in heart failure triggers benefit for heart failure. And this has been the missing link, which we have realized quite late. The other thing to remember is heart failure in diabetics is frequent, although missed on many occasions. It is often forgotten for various reasons, and it used to be fatal, but now with the current pharmacotherapy, we are powered to improve the outcome of HFrEF to a great extent. Here you can see diabetes mellitus is an independent risk factor for heart failure. Diabetes mellitus increases the risk of heart failure 5 times in women and 4 times in men. In patients with chronic heart failure, 25% are diabetics. In acute heart failure, 40% are diabetics. And the prevalence is higher in general population, almost to the tune of 4 times. Why diabetes produces heart failure? As you can see here, it produces hyperglycemia, insulin resistance, hyperinsulinemia, activation of the RAS, which produces cardiomyocyte hypertrophy and fibrosis, and the patient ultimately ends in HFrEF. It also produces inflammation, dyslipidemia, and endothelial dysfunction, which produces CAD, and that can land you in heart failure with reduced ejection fraction and on several occasions you have diabetic cardiomyopathy without coronary artery disease, that can also land you in HFrEF. If you have a diabetic heart failure, you are 7% increase in the risk of cardiovascular death, 8% increase in the risk of all-cause mortality, and 27% increase in risk for HF hospitalization. And I've already told you, every hospitalization and rehospitalization takes the patient closer to death. And we've already seen the 5-year mortality in diabetic heart failure is to the tune of 85%. So let's see a case of diabetes with heart failure and how do we go about it. 62 years old male, diabetic since 2 years, height 179, weight 82, which means overweight, BMI 26.6. He's on metformin and vildagliptin. And during a routine checkup, he complained of swelling on the legs and shortness of breath while performing his daily routine activities. And you can see here, ejection fraction is very low, 23%, good HbA1c, NT-proBNP very high, systolic blood pressure reasonable, eGFR 63, which means stage 2, CKD, serum creatinine 1.15. So in short, this patient has HFrEF stage CKD 2. What should be the treatment for these patients? The ACC 21 has recommended ARNI as a preferential therapy for HFrEF. I'll tell you what are the reasons for it. But the other 3 foundational drugs have also to be used, which means beta blockers, MRAs, and SGLT2 inhibitors have also to be used in conjunction with ARNI. Now, this is a very exciting data of sacubitril valsartan on ARNI from the PROVE-HF trial. There is great reverse remodeling in patients with heart failure. You can see the ejection fraction is increased by 33%, left ventricular end diastolic volume decreased by 14%, left ventricular end systolic volume, which is a predictor of reverse remodeling, decreased by 25%, left atrial volume index decreased by 20%, E by frame ratio again, which is an index of diastolic dysfunction, is decreased by 11%. And this is a very, very interesting data. When patients of PROVE-HF trial with ARNI were analyzed on the basis of ejection fraction less than 35%, all of us know if your ejection fraction less than 35%, it is an indication of ICD. So 613 patients, when they were analyzed, within a period of 6 months, you see a dramatic effect. 32% of patients whose ejection fraction was less than 35%, it became more than 35%, clearly meaning that these 230 patients will not require ICD. At the end of 1 year, you can see as much as 61%, the ejection fraction became more than 35%, which means within a spell of 1 year, 61% of patients who required ICD will not require ICD. And this is indeed very, very exciting data from the PROVE-HF trial. And interestingly, none of these patients had sudden cardiac death during this spell of 12 months. And this shows within 6 months, you can have an ejection fraction greater than 10% increase. And by the end of the year, maybe 15 to 20% increase. So a new thought is emerging for ICD implantation. Optimize use of ARNI before taking decision for ICD implantation for primary prevention of sudden cardiac death in patients of HFrEF with ejection fraction less than 35%. Why ARNI is recommended as a preferential therapy for heart failure by ECDP, which means expert consensus decision pathway ACC 20. The first reason is I've already demonstrated there is excellent documentation of reverse remodeling in the PROVE-HF trial. It converts ICD eligible patient into ICD ineligible patient, and this is indeed a great achievement and a great observation to be further tested in trials, which means if ARNI can prevent ICD implantation, this is a great achievement because ICD is a very costly device. So sacubitril valsartan is the preferred therapy now for over ACARB for all patients of HFrEF, as it is a superior clinical evidence. So HFrEF patients ejection fraction less than 40%, NYHA class 2 to 4, administer ARNI in conjunction with background therapy of DDMT for HF in place of an EI or IRB. And as I already told you, ARNI can be initiated as a de novo therapy, which means right from the beginning in patients with HFrEF who are naive to ACI or ARB, and one can say bye-bye to switch strategy from AC inhibitors or ARB to ARNI. And obviously it produces rapid improvement in symptoms, physical functioning, and the quality of life. But sometimes the patient is already on AC inhibitors. So what should be our strategy when we want to switch? If the patient is previously on AC inhibitors, make sure that 36 hours should elapse before you initiate ARNI. If the patient is taken an equivalent amount of less than 10 milligram of enalapril or equivalent of less than 160 milligram of ARB like valsartan, you can directly initiate with 50 milligram twice daily. If the patient is taking equivalent to greater than 10 milligram of enalapril or equivalent of greater than 160 milligram valsartan, 100 milligram twice daily, and slowly you can optimize it to the target dose of 200 milligram. Obviously, you have to monitor blood pressure, eGFR, and potassium levels. Additionally, sacubitril valsartan also decreases the necessity of insulin and also produces several other advantages. As you can see here, when neprilysin is inhibited, there's increased natriuretic peptides, which increases insulin sensitivity. Increased bradykinin also increases insulin sensitivity. The GLP level increases because the DP4 activity is less, and there's increased skeletal muscle CGMP, which facilitates lipolysis and vasodilatation. So sacubitril valsartan provides a 25% reduction in the risk of cardiovascular death, 20% reduction in HF hospitalization, and a 17% improvement in the quality of life, improvement probably within 8 months. And you can see if you use this drug, there's a 0.14% greater reduction in HbA1c concentration over 3 years with sacubitril valsartan, and 29% reduction in the use of insulin in patients on sacubitril valsartan. These are the 4 foundational drugs. The ECDP has recommended ARNI as a preferential recommendation, but don't forget, treat all these 4 drugs as complementary to each other and never as competitive. All 4 drugs should be on board as early as possible within a period of 1 to 4 weeks, taking into consideration the heart rate, the blood pressure, eGFR, and the potassium levels. What about SGLT2 inhibitors? SGLT2 inhibitors are also indispensable for heart failure reduced ejection fraction, heart failure, preserved ejection fraction. They are a therapy across the range of heart failure. Here you have the Diabetic HFrEF trial, which showed improved outcome of HFrEF, 10 milligram per day. We have the Emperor reduced, similar results, Emperor 10 milligram per day, and we have Emperor Preserve, which also showed improved outcome in HFrEF, again used in the same doses. The other big advantage is that if you use a comprehensive therapy, which means using all these 4 foundational drugs and compare with conventional therapy, what is the result? You can see the cardiovascular death or hospital admission for heart failure, there's a decrease of 42%. Cardiovascular death, decrease of 50%. Hospital admission for heart failure, which is so important, 68% reduction. In all-cause mortality, 47% reduction. So comprehensive therapy, which means all 4 foundational drugs help in halting or delaying the clinical progression of HFrEF patients compared to the conventional therapy. And this is a very interesting data on the event-free survival. If you use all 4 drugs, you can increase the event-free survival by 8.3 years. If you initiate at the age of 55 years, and by 6.3 years if you initiate at the age of 65 years. So earlier you initiate the therapy, better are the results. And when you look at the terms of survival of patients of heart failure, you can see if you initiate at the age of 55 years or these 4 foundational drugs, you can increase the survival by as much as 6.3 years. If you initiate at 65 years, you can increase survival by 4.4 years. So in HFrEF patients with diabetes, like our patient Vikas, choose the optimal GMP, which means a preferential use of ARNI, and then use the all other three drugs, SGLT2 inhibitors, beta blockers, and MRAs. So what should be the strategies while using these four foundational fantastic drugs for HFrEF? All patients of HFrEF should be on all these four drugs within a spell of 1 to 4 weeks. All four drugs must be escalated to the target dose if possible and feasible, because heart failure, once sets in, runs a malignant progression, and heart failure is devastating. You can suddenly die of a sudden cardiac death in heart failure class 1 or 2, or you can suddenly get hospitalization for heart failure without any warning signal. So one should never try to de-escalate all these foundational drugs if the patient is tolerating. Polypharmacy is the rule, and the family should be motivated right from the beginning. The disease has a malignant progression, and polypharmacy has to be used even if you don't have too many symptoms. Cardiorenal continuum, I showed you, should be targeted and not with heart failure alone. And interestingly, ARNI and SGLT2 inhibitors target both the components of the cardiorenal continuum. But the big message is all these guideline directed therapies are highly underutilized in the Western countries, in the Indians, and we must make vigorous attempt so there's all these fantastic therapies are utilized by large number of patients so as to improve the outcome of heart failure. Thank you very much for your kind attention.
Thank you, sir. That was a wonderful lecture. And any questions? So how soon would you, basically, we know that once a patient is a diabetic, we know that they are going to eventually have some cardiac dysfunction. So what is the point at which you say, okay, I want to initiate the treatment to prevent to improve cardiac function, basically?
See, we have 4 stages of heart failure.
Right.
Drugs like SGLT2 inhibitors can be initiated in stage 1, where you have only risk factors and no cardiac involvement. Stage 2, where you have left ventricular dysfunction, patient has no cardiovascular system, you can initiate ARNI, you can initiate SGLT2 inhibitors, you can initiate beta blockers. Once the patient goes to stage 3, you have to initiate all these 4 drugs at the earliest so as to prevent transformation into stage 4, which is a very serious event in the natural history of heart failure and may require serious therapies like LVAD and even cardiac transplantation or device therapy like CRT and others.
Thank you, sir. Thank you so much for your time and your lovely explanation. It was so detailed. Even somebody who did not understand can understand everything thoroughly. Thank you so much for your time and effort. And I'd like to invite the next chairperson.
Manoria, sir. Thanks a lot. I have one question, sir.
Yes.
That when we are using these drugs, the patients are coming to our clinic with very low BP. 80 systolic, 90 systolic. So how to manage, whether we should continue or reduce the dose?
See, low blood pressure is a common phenomena in patients with heart failure. If your blood pressure is 100 and above, all these 4 drugs can be initiated easily. The issue arises when the blood pressure is 90 or roundabout. Now, faced with such a situation, you must check that your patient is not on unnecessary drugs for heart failure. For example, many of these patients may be on nitrates, which may not be required at this stage of the disease. So withdraw nitrates. If your patient is on carvedilol, which produces greater reduction in blood pressure compared to other beta blockers like bisoprolol, so carvedilol should be shifted to bisoprolol. Check whether your unnecessary dose of diuretic is not being used, because diuretic have role only in the early stages. So reduce the dose and check hydration. If hydration is not correct, try to correct hydration. Many of the patients are on alpha blockers. If it is possible to withdraw. So first you should try to adopt all measures which are contributing to fall in blood pressure. After this, if your blood pressure is still low, try to initiate those drugs which do not decrease blood pressure. So the first initiation in this subset patient will be an SGLT2 inhibitor, because SGLT2 inhibitor does not decrease blood pressure, does not decrease potassium, does not decrease heart rate, and does not affect the heart. You can also initiate ibuprofen if the heart rate is more, low dose beta blockers can also be initiated. And when we initiate both these drugs, the blood pressure increases. Because of increase in the blood pressure, the renal blood flow increases. The EGFR may also decrease if it was, it may also increase if it was less. So then you can use the other two drugs. Sometimes you have that the EGFR is less than 30 and one may be afraid of using an ARNI. Under such circumstances, we first try to unload the heart by drugs which do not decrease EGFR. For example, you can use hydrogen and isosulfide nitrate. Try to unload the heart. If patient is having acute myocardiopathy, you can put an intra-aortic balloon pump. And once the LV gets unloaded, the blood flow to the kidneys increases, the heart failure improves, and the EGFR also achieves a favorable trend, and then you can initiate the other two drugs. So SGLT2 inhibitors, ivabradine, low dose beta blockers, sometimes we can use also trimetazine, which has also a favorable effect. So under certain circumstances, some drug can be initiated early. Under certain circumstances, all the sequence of initiation varies depending on the four determinants of initiation: heart rate, blood pressure, EGFR, and potassium level. So you have to first get a basic information. What are those? After those, you can easily decide which drug should be initiated first.
All right. Thank you, Manoria sir. This was a very enlightening session. Thank you for your time. Thank you for explaining everything so much in detail. And thank you for gracing us with your presence and making this a success. We'd like to move on to the next topic.